All right. Hello, everyone. Nice to see so many of you here. I'm really excited for today's session because I get the privilege of discussing with Rabih, which is always so much fun. I learn so much every single time. As always, we rely on the audience to present a case that they have. So if you would like to present a case today, raise your hand, put your name in the chat, unmute. And we also wanted to give kind of a shout out to the people listening now and on YouTube about a case review committee that we started with the team. So kind of the reasoning behind this committee is that, as I said, during these sessions, we always ask the crowd if anyone would like to present a case. And sometimes, I remember before I presented my first case, it was kind of nerve-wracking. You don't know how formal it's going to be. And so really the purpose of this case review committee is to kind of help give you support before presenting a case. So what it entails is you send an email to theclinicalproblemsolvers@gmail.com saying, hey, I would love to present a case and would just like a little bit of support in preparing it. Then give a short summary of the case. And then basically one of the team members reaches out to you and schedules a meeting with you to go over the case and get to know you. I personally just met with someone with Yasmin the other day, and it was so fun because we just basically hung out, chatted, and got to know each other, and also talked about the case and kind of the format of presenting. But all of this to say, really, really encourage you to present. It's helpful to kind of build confidence on presentation skills. It's fun to just meet new people, and you can also put on your CV, which is always a plus. So really, really encourage you to do so, and encourage you to present any cases that you have. So after that rant, let's see if I inspired anyone to present a case.
You did.
More like there was already one that existed while you were doing that rant. So.
Oh, okay.
Hey, Drew, I have one question for you. Is the patient over the age of 18?
Yes, they are.
Woo! Good.
Oh my God.
although I did put in that if there are any under 18 cases, I would, who knows, maybe if you guys need an expert, then.
You will definitely have the expertise in that realm, but I'm glad that we're talking about somebody who I would legally be allowed to take care of.
Well, then again, the ACP does say that age 13 and above should be.
Oh, really?
Yeah, for IM.
So well, that's how competent I am. I don't even know the actual age. So there you go. I think that further reinforces my point, Drew. I just wanted to say a quick welcome to everybody. It's a delight to have so many of you here and to have so many CP solvers folks here. I see David on commuting after a long time. It's so nice to see you, my friend. And a lot of familiar faces. If you can, please turn on your video. The whole point is to build community and get to know each other. So it really, really makes a massive difference for us. I know maybe for you, it doesn't, you're looking at the same thing, the screen, but for those of us discussing and talking, we really just want to get to know all of you better. And the medicine is really how we communicate, but it's all about the people here. I just wanted to also say hi to Kirtan, who was kind enough to join us amongst his very busy residency schedule, and even had a case for us. But I'm sure he'll enjoy trying to solve somebody else's case today. So Drew, thank you for coming, and please jump right in. We'll have Maddie dissect this case, and I will try to add anything if there is anything to add.
Yeah, well, it's first day of me being 30 years old, and I figured that I'd celebrate it by giving you guys a
happy
cake.
birthday!
Oh, is today your birthday or yesterday?
Yes, yesterday was.
Oh my gosh! Happy birthday!
I was going to try to present yesterday, but unfortunately I got very sleepy because I was flying home to see parents and my pup, who is currently right next to me, kind of just walking.
Aww.
So.
Well, happy birthday.
So, all right. Whenever you just gotta wait to see where the whiteboard is.
Let's see. I think Shema is scribing. Let's make sure Shema
I have to become co-host.
Co-host,
I had one job, y'all. I had one job.
your one job.
All right, Shema. I think I fixed my many mistakes. One of my many mistakes. There you go. Thank you, Shema.
All right.
Go for it.
So we have a 57-year-old gentleman who presents with aphasia and right-sided weakness.
All right. So do you want to pause here?
Yeah, I'm going to leave it there for now.
Okay, perfect. So aphasia and right-sided weakness. So these are two complaints, two neurologic complaints, and based off of Aaron's phenomenal neurologic teaching, we know that the DDX is the localization times the time course. So that's really going to be kind of the framework we want to use to approach this. And we don't have the time course yet, but that's really going to be absolutely critical here. If this is like acute onset aphasia and right-sided weakness, kind of an alarm is going off in my head that we need to address this quickly. Maybe this is a stroke, a bleed. We need to get kind of a non-contrast CT scan and kind of activate a code stroke. So all this to say the time course is critical. So with aphasia and right-sided weakness, so if I'm remembering correctly, so aphasia, you really want to distinguish that from dysarthria, I believe. So if I'm remembering correctly, so I think dysarthria, just to distinguish that a little bit. So dysarthria, my understanding is more like inability to kind of articulate. I think I remember Reza describing it as like hardware versus software. And so if dysarthria is more of like an issue with the hardware articulating, you know, with everything in your mouth, tongue, I think aphasia is more of like a software issue, kind of a inability to, I'm not sure what the actual definition is, but like inability to, I'm not sure what the actual definition is, but it's more of like a software issue with language. And then the right-sided weakness, you know, we'll have to go through kind of the whole motor pathway. So is that something in the motor cortex and the upper motor neuron, the spinal cord, the lower motor neuron, the neuromuscular junction, the muscle here? So to tie these two together, I think the fact that there's aphasia and also unilateral weakness, I think with both of those, I'm concerned with more of a brain issue rather than a peripheral issue. But so that was kind of my rambling to try to figure out kind of the differential here. But in terms of next steps, the time course is absolutely critical here. I'd want to know if this person has experienced anything like this before, any other kind of focal deficits, but I'm pretty concerned right now because these are just very concerning chief concerns. And I'll pause there and would love to hear, Rabih, how you're putting these two together.
No, I think you're absolutely right, Maddie. I think you have to distinguish aphasia, which is basically that the apparatus in the mouth is not getting any signal at all about how to actually get the words out. Like there's nothing coming in, it's completely blank. And so what the body does then as a result is really just make up words, have a hard time saying words, so on and so forth. Dysarthria is the signal is coming, but the actual apparatus to execute it is dysfunctional in some way, shape, or form. So the words are coming, but they sound really weird and off, and they're flowing just fine, but they make no sense. And the best way to understand dysarthria is to remember what somebody sounds like when they're intoxicated on alcohol. That is dysarthria, and that's cerebellar dysarthria. In stark contrast to aphasia, where you might see that somebody just cannot say anything, cannot understand, so on and so forth. So I think that's really, really important because dysarthria is a cranial nerve issue, a muscle issue, a brainstem issue, or a cerebellar issue, where aphasia, in stark contrast, is a cortical phenomenon, usually in the dominant hemisphere. And I think I think here the thing to really realize is if you're taking care of this patient and you are really following the exercise that Drew is giving you, you're going to need to know 4 things in the next 10 seconds, truly, or ask for 4 things in the next 10 seconds. And those four things are: what is the last known normal? What is the blood glucose? What is the blood pressure? And is the patient on anticoagulants? Like those four things you'll need to know right away. You may not need to know the last three if the last known normal is beyond a day, because all of a sudden you're not activating a code stroke, and the glucose and the blood pressure and the last known the glucose, the blood pressure, and the anticoagulants become less relevant. But that's what it would be like in real life. Another high stakes thing in real life is a phenomenon that's well described in the trauma world. So surgeons who take care of trauma patients. Raise your virtual hand if you've heard of the distraction phenomenon. Please. Anybody heard of it? It's a tricky thing to recognize, but it's the idea that if a patient has a cervical bone fracture, their neck is broken, they're very, very unlikely to also tell you that their radius is broken, because the pain in the neck is so powerful and so strong that the patient forgets that they have a toe fracture or a small fracture elsewhere. And this is also something that happens in devastating neurological diseases. If somebody has weakness and cannot speak, you're in trouble, because you may miss something systemic outside the brain for two reasons. The first is that the patient can't really talk that well, can't give you a good history. And two, the patient is probably so distracted and so overwhelmed by the burden of neurological disease that they may not be able to tell you that they've lost weight, that they've had fevers, that they have had abdominal pain. So as you develop tremendous momentum towards addressing the neurological issue, you have to keep the lights on in the other room. And the other room is there a non-neurological dimension that is completely camouflaged by the sheer severity of the neurological features here and the patient's inability to communicate accurately? In most patients, the lights go off in that room by themselves. It's just fine. But in some patients, those lights become profound. And I will tell you that I made this mistake and will try never to make it again in a case on RLR CP solvers that Aaron Berkowitz presented. And because it's been a month, I'll spoil it for you. It was a patient who came in who had aphasia and right-sided weakness. And it's the exact same presentation. Turned out to have a left cortical hemorrhage. And everybody was like, oh, okay, what's this hemorrhage? It turned out the patient had endocarditis causing the hemorrhage, and it was emboli. And the patient, when he could finally talk after all this, said fevers, chills, night sweats, weight loss. Really, really humbling case. So to summarize, I'll just repeat, Maddie, what you said. The concern should be that this person has a left-sided cortical lesion because the aphasia software issue. And the time course is going to be key. If the time course is less than 24 hours, you're going to want to know glucose, blood pressure, anticoagulant, and be very, very attentive to a non-neurological dimension of this case that may not be picked up on history, because there won't be much history, maybe, unless there's collateral from family. But it may be that the patient has a low-grade fever, or the patient is tachycardic, or the patient has a white count. All those things are going to be really important. All right, Drew, tell us more, please.
All right, well, I'll give you one of those last four, because all the other ones are in several of the next aliquots. So last known well was 3 hours prior to him coming to the attention of our service. And so, give me a second, because I'm flipping, but again, forgive me because I'm flipping between two different medical records. Yeah, so he actually developed the symptoms at work at that time, and he basically was difficult to express words. He just was weak on his right side, didn't feel well, and his son was with him and called EMS. And when we got the history later, he hadn't had any history of prior strokes or any other focal weakness, numbness, gait changes, speech changes, or anything like that. He doesn't see doctors, so he has no known past medical history. And he doesn't take any medications at all. In terms of family history, his mother had a history of strokes, multiple of them in her 60s. And his father had an MI in his late 40s. He has an 18-pack year smoking history and still smokes. Drinks about 2 drinks on the weekends. No other drug use. And he's a meat packer. Makes sausages and everything.
All right. Do you want to give more, or should we pause there?
Let me just make sure that actually, you know what? So yeah, so actually I gave you 2 of the things that you guys wanted. The third thing I'll give you in the third aliquot, and I'll also, actually no, I'll give the rest of the 2 in the third aliquot.
All right, so we'll pause here, Drew?
Yeah.
Okay, so, you know, after the first aliquot, even when we didn't know the time course, we really wanted to rule out a stroke. That's what we were concerned about. And this is acute, so I am very concerned about a stroke of some kind, and really kind of we need to act fast here. So let's see. Some of the information you gave is that doesn't see any doctors. So of course, we all know that just because he doesn't see any doctors doesn't mean he doesn't have other past medical history. It's just not known. But the information we do have, it sounds like he does have a smoking history, which we know is a risk factor for strokes. So that just kind of further puts my concern there. And then you gave the family history about a mother with strokes and a father with an MI in his late 40s, which is, you know, on the earlier age. So all of this to say is that I'm concerned about a stroke here. As we said, like the blood pressure would be important. We would want to get him to get a non-contrast CT scan. And kind of the additional information that we got further supports that concern. The meat packing history or job, I'm not quite, you know, tying that into my differential right now. That's a really interesting detail, but I'm not incorporating that into my thinking as to what's going on here. So the summary, kind of, we need to act fast because this is an acute presentation, and get the blood pressure, vitals, and get him into the non-con CT scan. Rabih, what do you think?
You're so practical and wise. I completely agree with everything you're saying and doing. And my only role here would be to showcase to you how it's so accurate to have a complete understanding of the story. And I'm going to show you that's what I was scribbling. So, piece of paper. On this piece of paper, on the top, there are 2 different time courses. One where the symptoms begin abruptly and continue to progress and get worse and worse and worse over time. And the other at the top is one where symptoms begin so abruptly that they reach their maximal onset in seconds, and then they stay the same. You can see, if you look at this graph, that both patients are at the same point on the graph at the end of the conversation. See that? Mm-hmm. On the same point, but they got there 2 different ways.
The first is a patient whose symptoms began and they got worse. And the second is a patient who got to the as bad symptoms as possible, and then they stayed the same. So you can see how when you're getting a history from the patient, they'll both describe to you that they're at the exact same point, and only if you ask advanced history can you distinguish these two graphs. So I'll ask you all in the chat, or you, Maddie, out loud if you're inclined. Like, what do you think the value of this is, and what can this tell you? I'll give it like 30 seconds just for the sake of time, because I think it's important. Put your thoughts in the chat. Awesome. Yeah. Ibrahim, Abdurrahman, beautiful thought. Perfect.
Yeah, just to kind of say out loud for people who listen after. So some of the great thoughts in the chat are that, for example, if a patient has a hemorrhagic stroke and is still hemorrhaging, you know, the graph that Rabih's showing with kind of the symptoms might continuously be progressive rather than immediately symptom onset and then it plateaus.
Superb, yeah, 100%. So this, much more likely an ischemic stroke. This, very concerning for a hemorrhagic stroke, to the point where the patient might be untended very, very soon. Now, a harder question. The patient here is also at the exact same time point that the other patients are. But what's different here is the onset is a little bit unusual. And the squiggly line at the bottom is meant to signify that the patient wasn't exactly normal before this, but wasn't that bad. What is this? Ischemic that would hemorrhage later. Awesome. Subarachnoid hemorrhage with sentinel bleed. There are so many possibilities for this. This could be a tumor that bled. It could be a sentinel subarachnoid hemorrhage. It could be a slowly expanding subdural hematoma. But what does this tell you? It tells you you really need to know this phase. You really, really need to know this phase. And which is why I loved that Drew was told us as much as he could that this patient was at work. Very, very helpful clue. It's not perfect, but we are assuming when we're thinking of strokes, we're assuming normal at onset, but we don't know yet if this is happening.
So what's the point of this conversation is just to show you the sheer amount of complexity that can belie these cases, in large part because the history is so tricky to obtain. So there are so many dimensions of complexity. The first is, are there any non-neurological features? We won't know for a while. And then two, what is the rate of progression of the disease? And also, was the patient truly normal to begin with? So in these patients who you're rushing to the scanner to understand them, just be ready for complexity to emerge. And the reason you may not have anticipated is because we didn't know non-neurological dimensions, and we don't know the severity of the patient's symptom complex before onset, and we don't know fully the trajectory of disease. There's a lot, all these things are on history, just to show you how powerful the history is. And most of these patients end up with an ischemic stroke. That's much more common than anything else. But just to go, so it goes to show you how if things go in a different way, the lesion is often, we didn't know there was no non-neuro issues. We weren't sure what the start was, if it was start from normal or start from abnormal. And we didn't know what the trajectory was. Was it a skyrocket to abnormal followed by plateau, or was it worsening? So much in the history here that we don't get, which hopefully allows you to savor a very high quality history in other circumstances. All right, Drew, tell us more, please.
All right. So let me get you your vitals real quick. So when he came in, temperature of 36.9 Celsius. Heart rate of 58. Blood pressure of 151/90. Rest rate of 14, saturating 97% on room air. And in terms of his exam, he's alert, but aphasic. Can't really speak at all. Pupils were equal, round, reactive to light and accommodation. His visual fields were full. All of the rest of his cranial nerves were normal as far as I can tell. I'd have to check the actual stroke scale to check and see.
And was someone put this in the chat as well? Was a fundoscopic exam done at all?
With how quick it all went, I don't think it. No, it wasn't.
No problem.
Give me just a sec because I'm trying to get to the. See if I can find the original stroke scale.
I'm really sorry to jump in, Drew.
Basically
We're already
oh no,
at the 30-minute
running
mark.
over time.
Do you wanna
But
just
let me
do it. Yeah, do you want to just do it from memory? Because you know the details don't matter. Whatever stuck with you,
Yeah.
whatever narrative.
Well, bottom line is that he had
Yeah.
right face leg weakness and his expressive aphasia. His stroke scale was 14. Glucose was normal at 83. They got a head CT, which didn't have a bleed at the time, but when they did the CTA, it was the left distal M1 branch of the middle cerebral artery that was occluded. And so he got TPA. He went to the neurointerventional lab and got a clot taken out. But the main reason why I actually wanted to present this case was something that happened afterward. So he was put on aspirin, you know, all the things afterward. But when they got an echocardiogram, they found out that he had a left ventricular thrombus in the apex and regional wall motion abnormalities that were in the left anterior descending distribution.
Can we reflect about that, Drew? Is that cool?
Yeah.
Awesome. Wow. Thank you for taking us to the very juicy aspect here. Maddie, what are you thinking?
Yeah, Drew, thank you again for presenting this case. So, so I guess just to summarize kind of what you said. So we kind of established that this person had an ischemic stroke and clot was taken out. And then now we find out that there's a left ventricle thrombus in the apex regional wall abnormality in the LAD. So I guess the question is kind of, why is there a thrombus there? And, you know, potentially is that like, you know, the thumb, I don't know, is that kind of the etiology of the stroke here, the ischemic stroke? I mean, we can talk about kind of like Virchow's triad for kind of like thrombus formation, which is hypercoagulability, endothelial injury, and like abnormality in blood flow or stasis. And so let's see here. I'm trying to think what I should do with this.
Maddie, is it fair to say that?
Yeah.
Is it fair to say that? Do you have doubts on whether the stroke was caused by the LV thrombus, or is that a connection that you think is firm in this case? What do you think about that?
That's interesting. Yeah, I guess I noticed that leap was made kind of instantly in my head without much doubt.
Yeah. And I think that's wise.
Yeah.
you're saying that there's a big goomba of clot in the LV, and to conjecture that a small piece of it flew off and dislodged in the brain is very wise. And so now
Yeah.
it's almost like you're saying, just to vocalize the way your mind, you're like saying, well, hold on, how does somebody get an LV thrombus? Have you ever heard of a case or read a case or of LV thrombosis?
Not one that's coming
Yeah.
to mind.
Yeah, it's
Yeah.
not very common. In fact, the thing that you ended with by saying stasis, that turns out to be the most common reason why people get LV thrombus, is they have a big ballooned out MI.
Mm.
So going from that, like sitting in the stasis space, that really is, with one exception, the major driver for LV thrombus formation is that there's stasis. So you can think creatively now and engage your brain into like knowing that fact. Okay, like what could possibly cause stasis in the LV not to do its job of injecting? What do you think?
Yeah, and Seamus put this in the chat, but if the patient had kind of a prior myocardial infarction and was like dead myocardium there and not able to contract fully, and then stasis resulting in the thrombus, that's one way you could put it together.
That is by far and away the most common cause, Maddie. And I think if you use this case, this reminds me of your of the case we discussed a while ago with a mediastinal mass. And I remember that you like absolutely sat there, reflected on it, and took your knowledge from where it was to basically everything at the end of it. And I think if you're approaching an LV thrombus, you always want to recognize that the vast majority of patients have an anatomical abnormality in the left ventricle, and that explains it. So you go quite simply from stroke to LV thrombus to there's something in the left ventricle. Let me remove the thrombus and see what's there. And the only exception to that, the only thing that is so hypercoagulable that it can cause a spontaneous LV thrombus without any LV anatomical abnormalities is hypereosinophilia. And those patients can have a spontaneous LV thrombus without LV anatomical abnormalities. So you go here from ischemic stroke to I see an LV thrombus. If we explore that leap for a second, whenever you're thinking about the source of a stroke, it really falls into one of three categories. Is it a problem with the pump, like atrial fibrillation or an LV thrombus? Is it a problem with the pipes, the connection, usually atherosclerosis of the carotids? Or is it a problem in the plasma, something in the blood itself that is causing really hypercoagulable things like hypercoagulability of cancer or APLS or endocarditis? So think simply pump, pipe, plasma. And the way we do that in the ER is very easy. We evaluate the pump with an EKG and an echo. We evaluate the pipes with a CTA. That's why we get the CTA, to see what the pipes look like. Is there carotid stenosis? Is there an aortic issue? And then we get basic blood work to see if there's a plasma issue. Are the platelets low? Is the INR up? Things like that. So pumps, pipes, and plasma gets you most of the way. And in that workup, you found a pump issue in LV thrombus. And that's where you go, okay, LV thrombus, if there's no eosinophils, I really have to understand what the underlying anatomical issue of the LV is. And in most patients, that underlying anatomical issue is the patient had an LAD infarct causing an LV aneurysm or stasis in the LV. There are also other causes of LV stasis formation that are essentially non-ischemic causes of LV aneurysms. And that really depends on where you are in the world, because if this patient turns out to be from Brazil or South America, Chagas disease is notorious for doing this. In all of the world, though, you can get LV ballooning and stasis from Takotsuba's cardiomyopathy. And importantly, aneurysm formation isn't the only abnormality that can be seen in the LV. You can also have a genetic condition called LV non-compaction, where the cells in the myocardium are not quite compacted enough, and there's an macroscopic anatomical abnormality of the LV. But what do you think, now that you've heard a little bit of that, what do you think this patient might have? What's your best guess? Yeah,
so I really like that pipes, pump, plasma for stroke etiologies. So I think the regional wall abnormality makes me concerned of like a prior ischemic event, like a prior MI. So that's what I'm most concerned about. And Drew, was there any like aneurysm that was identified in that echo at all?
Let me just check and make sure. I think there was. Give me just a sec though. I gotta.
Oh, and Drew, while you pull it up, I think, Maddie, you're spot on. The most base rate would tell you this is ischemia. And then if you just look at the sheer rate of cardiovascular disease in the patient's family, it certainly reinforces that notion. The smoking, the hypertension,
Yeah.
mother with strokes, father with strokes, certainly reinforces that idea. And before I pass the mic to Drew, I think I'm so glad this case reinforced that point of non-neurological symptoms. If we're right, even if we're right or wrong, it doesn't matter what the patient has. This patient had a massive cardiac event, and we don't have access to that information either because maybe he didn't notice. But it goes to show you how you really have to not be launched into neuro without having a little bit of internal medicine left, even in the most pure neuro of case of stroke. Don't tell Aaron I said that.
Yeah. No, it was just a whole bunch of regional wall motion abnormalities. So let me just get the. Yeah, so basically it was hypokinesis of the anteroseptal wall, akinesis of the anterior wall, and dyskinesis of the apical wall. So it's all in the distribution of the left anterior descending coronary artery. And on top of all that, his EF was about 30 to 35%. And on top of all that, when we got blood cultures, he also had MRSA on top of that. So yeah, that was a thing. He did have a little bit of hemorrhagic conversion after he got all of this, and so there was some delays in figuring out, how much anticoagulation to do, but ultimately he ended up on warfarin and is now following up with both neurology and cardiology. So, and yeah, the likely he had a pretty big, I would say probably STEMI level MI in the LAD distribution that led to the things that led to the LV thrombus that led to stroke. So, yep. So yeah, final diagnosis for him, MI that led to LV thrombus that led to left MCA stroke.
Wow. Drew, thank you so much for presenting this. I think one just question on the case. So the blood culture is growing MRSA. How did your team think about kind of where that came from, and what was the thinking that your team had there? That really struck me.
It was the cultures were actually drawn. Oh, when did they get drawn?
And I think that actually kind of goes to Rabih's point about the distraction, distraction bias or
he fevered. That was why.
Okay.
So once he did, they got blood cultures, and yeah, it was like 1 out of 2 bottles grew MRSA. So
awesome. Well, thank you, Drew. Yeah, go ahead, Rabih.
No, I was just gonna say, y'all, I hope that that you were inspired by Drew's amazing case presentation skills to try this yourself and present cases. Drew has been part of this VMR community for basically since the origin of it, now almost 3 years when he was a medical student. And so I think this is probably Drew like case presentation 37 or something. And we're very, very grateful for it, especially grateful for such an educational case that spans the common stroke to the less common and probably an infected LV thrombus. Thank you. This is really, really educational. And Maddie, I really, really commend you for being very practical throughout this. It was really cool to see how you were so focused on what you would do next, and yet again, continue to articulate the spaces that you were going to reflect and refine and grow on. And for me, it's going to be trying to understand a little bit better the the lay of the land in terms of patients who get LV thrombus. And I also remember that the treatment of LV thrombus gets a little bit complicated in terms of anticoagulation because this patient's being started on Coumadin, which wouldn't be your default in most cases, but I think Coumadin or warfarin is still first line for an LV thrombus. So I have to refresh myself on that. But thank you, Drew. That was an amazing case. And Maddie, really superb discussion. I'm curious, Maddie, if you can leave us with, before we learn from Noah, this might be your last time discussing on Thursday as someone who's in the 3rd to 4th year of medical school transition. What has it been like now that you've had a few under your belt? Like, what does this feel like compared to what it felt when you started?
You know, it's always still like there's a level of kind of excitement and a little bit of nerves, which I think is a healthy amount, but I think it's a little bit more comfort with knowing that, okay, I will know something, but there's always kind of an opportunity for growth, and kind of using each case to practice some things that you're a little bit more comfortable with, like, you know, like next steps if someone has kind of acute focal neurodeficit, and then using each case to kind of pinpoint like, wow, you know, the distinction between aphasia and dysarthria, kind of, I thought I knew that. And then when I was prompted to out loud explain that, I'm like, wow, I really don't think I understand that. And then the same things with like stroke etiologies and etiologies of left ventricular thrombi. Like, it's such a cool opportunity to find the areas of growth. So, because it really challenges, it's a different kind of experience to be able to explain things out loud, and each opportunity is just a really cool time to practice this and find areas for growth and review. And Drew, I like really appreciate you presenting this, because I had the opportunity to grow thanks to you presenting this case. So thank you. I also really appreciate that it was like a kind of like a bread and butter, like this is like a very common case, and I really appreciate the opportunity to learn from it. And thanks, Rabih, for your amazing teaching.
Yeah, and to go back to Rabih's point, it was a couple of considerations for why he ended up on warfarin. One was the fact that he had an LV thrombus, and two, he was Mennonite / Amish, so he didn't have any insurance, so warfarin was the cheapest drug to use.
Thank you, Drew. And the practical elements of that are really helpful. You know, I just noticed we have a cardiology soon to be extraordinaire / VMR legend and Sukriti here. Hello, long time no see.
Hi, Rabih. Hi, Maddie. Hi, guys.
Hey, Sukriti.
Excited to be here.
It's so good to see you.
You should jump in and share your pearls on this.
No, I learned so much from your approach, Rabih. It was the stroke is such a bread and butter case, but I've never thought about it like this, and it was just amazing. I was just texting Keitha and telling him that I'm so happy to be here.
We're thrilled to have you. Really are. Do you have any pearls on LV thrombus or how it happens or management that you've seen in your career? I know you'll see a lot more in a few years, but anyone so far?
I think there was one, I really have to read more about it, but one challenging case in terms of management was we had a patient with coronary artery disease and LV thrombus. And really the point of debate was whether to do a high risk PCI versus a coronary artery bypass graft. And as you all know, like with a high risk PCI, one of the considerations was to use an Impella device, which is a mechanical circulatory device. But the problem with using that was dislodging the LV thrombus. So that was a particularly interesting case in thinking about the management. And just, I know there's been a lot of debate about anticoagulation with LV thrombus, because we don't have, there isn't robust evidence in terms of using DOACs, but we're seeing that more commonly. Cardiologists are more comfortable using it just based on anecdotal evidence and preliminary evidence. So that's interesting to explore, but I'm going to read more about it after this case too.
Me too. Thank you, Sukriti. That was a great pearl. I'll also be reading about it.
Amazing. You'll suddenly see like every CP solvers person in this Google search is full of LV thrombus after this case. But last but not least, Noah, take us home, please.
Hi, everyone. So today we were greeted by a neurological complaint. We reminded ourselves that neurological DDX equals to localization versus time course. So localization can be either central or in the periphery. When we have to distinguish hyperacute, acute, subacute, and chronic, this case was a hyperacute case. We also took a stab defining better what aphasia and dysarthria are. We had a wonderful way of remembering it with software versus hardware, aphasia being the problem of the software and dysarthria being the problem of the hardware. So we had a patient with sudden neurological symptoms, and there are 4 things you should ask this patient immediately. Last seen normal, what's the glucose level, what's the blood pressure, and is he on any anticoagulants? Those things are important when we're considering a stroke presentation. Talking about stroke, there are 3 actually time courses possible. Progressive versus a fast plateau versus a slow progressive with abrupt worsening. Sometimes they can be classic for hemorrhagic strokes versus ischemic versus other DDX respectively. So when asking this patient for the history, it's important to keep in mind what's the progression and if it was at baseline before the event. Our patient was at baseline, he was working, he had an acute event, so that's when we perked up for a stroke presentation. Also talking about the history, neurological patients as well as trauma patients can fall victim to the distraction phenomenon, which is when the patient is so distracted by his presenting symptom that he simply does not remember to tell you his other symptoms. The physician can also fall prey to this bias and can premature close a diagnosis without further inquiring for other symptoms. So we should keep that in mind when taking a history of those severe patients. In this case, the acuity, the family and personal risk factors are very concerning for stroke. They did a CT scan and was found to have ischemic stroke. The workup for the etiology comes next. So we have a framework of pump, pipe, and plasma. In this patient, we found a problem with the pump. So we had a stroke, an LV thrombus seen in the echo, also stasis, which was the cause of the thrombus. The stasis was caused by motion wall abnormality, and then we delved a bit in what could cause that. So LAD infarct, Chagas, maybe if this patient was in Brazil, cardiomyopathy, either genetic or acquired. Base rate and personal and familial history tells us that MI is the most likely cause in this patient. And we also quickly went through visual stride for thrombus formation, which is vessel damage, stasis, and hypercoagulable state. And that's all I have for today. Thank you very much.
No, I should look. You should look at the chat, and while you do, I'll tell you that I'm addicted to TikTok, unfortunately, and there are a lot of like TikTok videos where people are like riding on bikes and they chat and talk like on the bike. I feel like every time you do teaching points, I feel like you're sitting on your bike and taking us down the journey as we meet the neurological chief complaint. So thank you for your wonderful bike ride, and you should do TikTok teaching points. I think it would be a very powerful hit.
I'll keep that
On a
in mind.
bike.
On a bike, yeah. All right, y'all.
Birch triad on a bike. Yeah.
Thanks, Maddie. Thanks, Noah. Thanks, Drew. Thanks, everyone, for spending your hour with us. We really, really had a great time and hope to see you next time. Bye.
Bye, guys.